the video feed on unless you are, presenting or asking a question or something, yeah, because some of us may be having trouble with bandwidth. So if we switch off the video feed, it might make it easier for whoever is having difficulties. Yeah. Okay, I think we're waiting for 2 more students. Shall we give 2 minutes, and then we start at 2:40? Okay, maybe we could go ahead. Maybe we can go ahead and the others will join soon, inshallah. Yes, Sister Amira, I think, the first presenter. Yes?
Yes, Doctor.
Okay, do you want to proceed?
Okay, sure.
Okay, thank you.
Okay. Assalamualaikum warahmatullahi wabarakatuh. So welcome to our second seminar entitled Eczema. But before that, let's start the seminar with Al-Fatiha. Okay, so the outline of today's presentation, as being briefed by the doctor previously, which is I, Amira, would be presenting about the introduction and classification of eczema. And the next presenter, Ali, would be presenting about the atopic dermatitis. Hassan would present contact dermatitis, and Suriana would end our seminar with management of eczema. Is my voice clear? Okay, so
yes, very clear.
Yeah, okay. So when you hear the word eczema, what comes to your mind? Like if you hear the word eczema, most people would perceive eczema as the atopic eczema, the atopic dermatitis, the one that is related to asthma, allergic rhinitis. But the general fact is that eczema is not about atopic dermatitis only. It encompasses many types of eczema. And the interesting thing is eczema is derived from a Greek word means to boil or boiling. It is referring to the first stage, early stage or acute stage of eczema, which is the tiny vesicles eruption that resembles like bubble, like boiling. Right? Okay, so in terms of terminology, eczema and dermatitis is considered as synonymous. Although it is debatable, but they agree that eczema and dermatitis is the same thing. So if you say atopic eczema, it is also the same as atopic dermatitis. So let's go to the technical definition. It is a type of inflammatory reaction pattern in the skin that may be provoked by a number of external or internal factors. So there is a pattern, which is a characteristic clinical features of eczema. And there is, the second thing is there is either an external or internal factors. So we would discuss more about the clinical features in the next slides. Okay. So how common is eczema? It is said that about 20% of all new patients referred to this dermatologist clinic is about eczema or dermatitis. But the epidemiological approach of eczema is quite difficult to actually come to a conclusion of general prevalence. So they usually study specific eczema. And that's why they found that particular types of eczema may affect up to 29% of individuals in certain population. They cannot come into general prevalence. They just have to study the specific eczema. And the most popular type of eczema that is being studied is atopic eczema, atopic dermatitis. So globally, it may affect about 15 to 30% of children and 2 to 10% of adults. The male to female ratio is about 1 to 1.4. There's not much difference. And the most popular study approach that assess atopic eczema is ISAC. ISAC is International Study of Asthma and Allergy in Childhood, where they found, particularly in Malaysia, about 9.5%, they found in phase 1, prevalence of children with symptoms of eczema. And they found that there is an increment to 12.6% in ISAC phase 3. So there is an increase of 0.49% yearly in Malaysia. Okay, that is about atopic eczema. The other type of eczema that they do prevalence study is occupational dermatitis, because they found that 30% of occupational disease involves skin, which is 90 to 90% and 95% of the skin disease is about contact dermatitis, irritant or allergy. So it is common, really common. Next slide. Okay, so that is the two popular, right? The most known type of eczema. But there are many types of eczema, like less known to us. But today we are going to learn that dermatologists try to classify based on site, like where is the site of the eczema, like at the flexural or at the hand. They also try to classify based on age, like in terms of infantile eczema or senile eczema. However, the most acceptable or the most rationally used classification is the endogenous and exogenous. So endogenous is referring to the constitutional factors or internal factors, mainly in our body, intrinsic, and exogenous is the contact, external factors outside our body. So I list here that about two exogenous classification, which is primary irritant contact dermatitis and allergic contact dermatitis. These two will be further discussed in detail with Hassan. So endogenous classification, I list out 6. There is some more, but we can further read later. Okay, so endogenous classification, the most common one is atopic dermatitis. So the atopic dermatitis will be further discussed with Ali. So with me, we will briefly look through the other 5. Okay, next slide. Okay, the second one is seborrheic dermatitis. Seborrheic dermatitis, as you can see, the word seborrheic it means it is referring to seboria, which is there is an abnormally increased secretion of sebum and the formation of greasy scales. The initial stage would be like dandruff, but in seborrheic dermatitis, it worsened. There is itchiness, diffuse scaling, and erythematous because of inflammation. So it is associated with Malassezia furfur, which is a fungi, and it affects mostly at the scalp, face, external area, upper back, and flashes, where the sebum secretion area. Okay, and the clinical and it affects mostly immunocompromised patient, and it has something to do with genetic predisposition. Okay, next. Sorry. Okay, next. The next one is discoid eczema. Okay, discoid eczema is named after the shape, discoid. So discoid or nummular is referring to an oval shape, round, coin-like. Okay, so in discoid eczema, it is scattered, well demarcated, there is exudation and crusting eczema develop usually at the trunk and limbs. So in discoid eczema, it is intensely pruritic, the clinical features, and frequently it is associated with secondary bacterial infection, especially Staphylococcus aureus. It is also found that males has more commonly affected than females. However, the etiology is still unknown, but they found that most patients with discoid eczema has chronic stress. Interesting, right? Okay, next one is varicose eczema. Varicose eczema, okay, the name describes itself, which is it refers to varicose. Varicose means there is something to do with the venous insufficiency related to the chronic venous hypertension and lower leg edema. When there is lower leg edema, what will happen is there is eczematous changes of the skin. If you remember in surgical posting, we also know that there is changes at the venous insufficiency disease, venous leg disease. Oh, okay. So varicose eczema is also known as statitis dermatitis or gravitational eczema. Okay, next is endogenous eczema of palms and soles. Okay. This one, there is another name, which is pompholyx or dyshydrotic eczema. It is a symmetrical pattern of eczema affecting the palms and soles. So both hands would have the disease. It is chronic and it is called endogenous eczema of palm and soles if there is no external factors involved. Okay. But there are some endogenous eczema of, there are some pompholyx disease that has external factors, example like nickel. So it is a bit confusing why they put this under endogenous. Sometimes they has external factors too, like nickel. Example, okay. So it has an episodic form, which is acute pompholyx, which is acute stage of this eczema. There would be formation of bullae, and it develops really quickly and can be severely itch. The eczema can be associated with bacterial infection too, and usually it responds to potassium permanganate soaks and antibiotics like flucloxacillin and erythromycin. Okay, next. Okay, this is osteototic eczema, or known as eczema craquelé. It is about cracking. It occurs in elderly who is admitted in hospital. They bathe more frequently than they bathe at home. So what will happen is the skin will become dry, itchy, and cracked. Usually it is at the lower legs, abdomen, or it can occur anywhere. The pattern on the skin resembles a dry river bed. So the below picture is dry river bed. The upper picture is the crazy paving of the floor. Okay. So the skin is characterized like that. The underlying pathology is that the lipid content of the stratum corneum decrease. So when they bathe frequently, it can decrease. What is done to the skin is that it cannot retain the water, so that's why it cracks. Okay. And the next slide will show you the pictures of how the skin looks like. I don't know if you can appreciate it, but the first picture at above is a bit, I would say, it is okay. It is erythematous and there's excruciation. At the right side is more prominent, the crazy paving pattern, and the picture with the background, black background. There's, if you can appreciate it, yeah, you have to zoom in a bit. Subtle interweaving superficial features with low-grade scaling. Usually, we can see this in elderly, and they would be very, they would scratch it because of the itchiness. Okay, next slide. Okay, the next slide is about clinical features of eczema. This is the important one. What is going on in eczema is that when there is inflammation that occurs in the dermis layer, there would be vasodilatation. It can occur, the vasodilatation would leads to extravasation of the fluid into the epidermal. So this fluid would be edema in the epidermis, which is called spongiosis. So this edema would progress to the formation of intraepidermal vesicles. So it would separate the keratocyte, so become a vesicle. So this is called vesication. So this vesicle can combine or coalesce and become larger blisters, and it can also weep or exudate to the surface of the skin, or it can become a ruptured. Okay, so progressing, it would try to heal, and there would be crusting and progress to the chronic stage, which is after much after the vicious cycle of each scratch, inflammation, they will become chronic inflammation, which is more about the hyperplasia. It is less spongiosis. There is no vesication. It is more about dryness. Okay, because there would be more thickening of the precursor layer, acanthosis, and hyperkeratosis. Keratocyte would be hyperproliferate in the horny layers. Okay, so this is chronic lichenification. Next slide. So, okay, based on that pathology, we can appreciate what is the signs that could manifest in the patient. Okay, first, they would come to us with a complaint of principal symptoms of itching or dryness. But if we see the signs, it is more, we have to differentiate between the acute stage and the chronic stage. We can differentiate. The first primary sign is the ill-defined margin of the skin, because we want to differentiate between eczema and other types of skin inflammation. Okay, so because other scar is more sharply marginated. Okay, the acute stage has like just now inflammation, so eczema, and then edema due to vesication, papules, vesicles, and exudation or weeping. There would be surface scaling or none at all at the first stage, and there can also be bullous formation if the vesicle combine, and it can be associated with bacterial infection if there is a breach in the skin barrier, and would be presented with golden crusting. Okay, I will show you the picture later. So the next one is chronic stage. The difference is that they would have some of the symptoms, signs of acute stage, but it is less prominent. Like edema is not prominent. It is about xerosis, dryness. So there would be increased scaling and lichenification. Okay, and sometimes we can see polished fingernails due to the prolonged scratching and rubbing of the skin, and or post-inflammatory hyper or hypopigmentation. Next slide. Okay, this is the typical eczema. The first one is the early stage. So you can see the individual vesicles at the periphery, and the center is ill-defined marginated area of coalesced vesicle. So there is no absence of scaling at this early stage. Okay, lichenified eczema is a chronic eczema. So the epidermis has thickened and become leather-like. So surface marking is exaggerated, scale is present, and it can become excruciation if scratching. Okay, next. These are a couple of pictures here. You can see the center picture of the hand is lichenification of the wrist. There is surface markings, surface skin markings on the palms. Okay, the left side is a chronic lichenified eczema, and you can see that is hypopigmentation. And the right side, if there is bullae formation in acute severe one, is acute bullous contact dermatitis like that. That is bullae formation. And the last picture is infected eczema, which is characterized by golden crusting. Okay, that's all from me. These are my references. Is there any question?
Okay, thank you, Sister Amira. That was well done. Just going back to one of your slides where you showed endogenous versus exogenous, right? Yeah, I think it was just yeah, this one. That's right. Just want to point out over here that although this is a convenient classification, right, it's convenient for us to think in terms of dermatitis being predominantly endogenous or predominantly due to external factors, isn't it? But in actual fact, there is overlap. Okay, for example, patients who have exogenous dermatitis, like allergic contact dermatitis, right? One of the reasons that they are susceptible to develop exogenous allergic contact dermatitis is because of genetic factors. Okay, so genetic factors determining the type of antigen presentation and processing and T cell receptor which they have got, whether it matches that particular hapten, isn't it? So therefore, genetic factors do determine who is predisposed to develop allergic contact dermatitis, although the direct cause, of course, is an external factor. Yeah, but there's overlap with the genetic factors. You understand what I'm saying?
Yes.
Okay. And similarly, in endogenous eczema, although the primary cause, of course, is internal in the sense of genetic or other factors, yeah, but flare-ups are often due to external factors. Okay, the reason why the eczema flares up in case of atopic or other types of steatotic, for example, right, is often due to external factors causing excessive dryness of the skin. Yeah, so there is overlap between these two categories, but it's still convenient as a classification. It sort of helps us to think about the main causes of disease, yeah, in a particular type of dermatitis. Okay, any questions for the presenter? She has talked about the definition of dermatitis. She mentioned that dermatitis and eczema are considered as interchangeable terms. Right? And then she talked about the epidemiology of eczema, especially with reference to the local situation. Right? Then she talked about endogenous and exogenous dermatitis, and then she discussed clinical features, acute and chronic eczema. And here we saw some of the terminology that we discussed last week, isn't it? Because she was telling us about papule and vesicle and plaque. Yeah? And then she talked about lichenification. Yeah? So we're seeing some of the terminology over there. Right? Any questions for the presenter? Any doubts?
I want to ask, what is
Sure.
what is the difference between discoid eczema and dermatophytosis? I mean, how to differentiate if patient comes to us?
You mean clinically, what is the difference?
Yes, because it looks almost the same.
Okay. Sister Suyana, I think, is controlling the presentation, right? If you can move forward to the discoid eczema slide. Okay. So over here we see discoid eczema, right? Clinically, it looks like round plaques. Okay. The interesting thing with discoid eczema is that quite often it starts off as acute eczema with, intensely inflamed erythematous papules and vesicles all grouped together to make this round shape. Subsequently, it becomes dry and scaly chronic eczema. Okay, and that's basically what we can see in the picture, isn't it? It's past that acute stage. It's going towards chronic discoid eczema, right? But you can see the round shape of the lesions. Now, in tinea corporis, right, although the lesions may start out as discoid plaques in some cases, but the typical feature is that the center of the lesion heals while the periphery of the lesion continues expanding. Okay, so the center of the lesion becomes almost like normal skin. And that's what gives rise to the annular shape. I think last week we discussed annular plaque, isn't it? Annular meaning ring-like. Okay, so in discoid eczema, we'd expect to see some degree of central clearing, some degree of healing in the center of the lesion, but with active erythematous, raised, scaly margin, okay, at the periphery. Does that explain the difference, brother?
Yes, thank you, doctor.
Okay. Okay, Sister Shafira, is there any other risk factor for dyshydrotic eczema? Can we go to the slide for dyshydrotic eczema? I think you passed it. You passed it already. Yes. Before this? The palm and sole. The one about the palms and the soles. Omphalic is the other name for it. This one, yes. Yes, sister. Okay, so this one, omphalic, also known as dyshydrotic eczema, right? So I think over here, Sister Amira mentioned, I remember her saying stress as one of the factors. Did you mention anything else as a risk factor or precipitating factor?
I mentioned about nickel. It is associated to nickel allergy.
That's right. Okay, that's very good. Yeah. What they have found actually is that both discoid eczema and pomphalics, right, there tends to be some association with atopy. Okay, probably more strong with discoid eczema. Yeah, but also in pomphalics to some extent, there can be association with atopy, like atopic eczema, right? But of course, the interesting association is the one that she mentioned about nickel. Okay, so a similar pattern of eczema, which presents just like pomphalics or dyshydrotic eczema, can also be seen in patients who have got nickel allergy. Some patients. Okay. Another differential diagnosis would be, interestingly enough, tinea. Okay, tinea pedis particularly. Okay, so why is that? Well, tinea pedis, of course, you can have inflammatory type of tinea pedis on the sole, right? But in some cases where the tinea pedis is, quite severely inflamed, right? It can affect, although it started on the feet, it's tinea pedis, it can produce an eruption on the palms also. Okay, and that's not directly because of the fungus. It's basically an immune-mediated. It's an allergic type of reaction occurring on the palms. Okay, so they call that an id eruption. ID, id eruption. Yeah, usually the word id is more closely associated with psychiatry, right? Did they talk about id when you had your 2-week posting? Okay.
Yes.
But yes, but this is a different type of id. Okay, it's not the same one, right? This is called an id reaction because it's a secondary allergic phenomenon, right? And it resembles the presentation of pomphalics. Okay, so that would also come in the differential diagnosis. Does that answer your question, sister? Okay. Any other question for the presenter?
Saya kan doktor.
Yes.
Doktor, I want to ask how to differentiate seborrheic dermatitis with scalp psoriasis?
how to differentiate seborrheic dermatitis from scalp psoriasis.
Yes,
Okay.
because
You want to address that one? It's a good question. Maybe we can go back a couple of slides to seborrheic dermatitis. I think that was number 2. Yes.
For seborrheic psoriasis, it is more sharply marginated.
Very good.
If seborrheic dermatitis, it's ill-defined.
Good.
And then in terms of itchiness, seborrheic dermatitis is mild. Oh yeah. And there is diffuse scaling on erythematous background. For psoriasis, it's the same in terms of itchiness. Okay, I think it's I can differentiate only in terms of the margin.
Okay. Well, no, actually there are more differences, you know. We haven't done psoriasis yet, so maybe it's a bit unfair for me to ask you. But there are a few more differences. Seborrheic dermatitis, as you say, it tends to be sort of a diffuse erythema, okay, on the scalp. Whereas, and it's only slightly infiltrated, slightly raised, slightly elevated, okay. Whereas psoriasis on the scalp tends to be discrete, well marginated, well localized plaques, okay, very definitely raised and well marginated. You can see the difference between the affected skin and the normal skin quite easily with psoriasis, okay. And another point is that seborrheic dermatitis commonly involves the scalp and the face, okay, whereas in psoriasis, involvement of the face is less common. Okay. Usually in psoriasis, the lesions on the scalp, they will end just beyond the hair margin. Okay, so usually it won't sort of diffusely spread onto the forehead and then the center of the face like you're seeing in this picture of seborrheic dermatitis. Okay. Seborrheic dermatitis, not only that it commonly involves the face, but there are certain areas on the face that are typically involved. Okay, for example, the medial end of the eyebrows. Okay, I think you can see in the lower picture, right? There's quite a bit of scale over there, isn't it? The medial end of the eyebrows, yeah? And then the eyelids. The eyelids are commonly affected. Okay, the nasolabial fold. Okay, on either side of the ala nasali, right? You can see in the upper picture, right? Nasolabial fold is involved. Okay, so also the retroauricular area, we can't see in this picture, but the area behind the ear, immediately behind the ear, will also be involved in many of the patients. Yeah? So it's got a distinct pattern to it. Yeah? Then, of course, if we look at the rest of the body, right, patients with psoriasis often have psoriatic plaques on the typical sites, you know, like the knee, the elbow, extensor aspect of the forearm, lumbosacral region, the lower back, and also nail pitting. Yeah, we saw an example of nail pitting last week in the picture. Yeah, whereas patients with seborrheic dermatitis, they don't have that pattern. Seborrheic dermatitis tends to be flexural on the trunk. Okay, so it goes to the antecubital, the popliteal, yes, and it goes to the center of the trunk, right? It goes to inframammary region, flexure again, isn't it? Right. So you know, there's definitely a difference in the pattern, and no nail involvement. Okay, so it's possible to make out the difference between seborrheic dermatitis and scalp psoriasis in most of the patients. Yeah, sometimes there may be overlap. Okay, there may be patients who have got features of both. But usually it's possible to make out the difference. Does that answer your question?
Yes, thank you, Doctor.
Okay. Anybody else? Okay. Thank you, Sister Amira. That was well done, well explained. Okay, so we'll move on to the next part of the presentation, atopic dermatitis. Brother Ali.
Okay, Assalamualaikum. My name is Ali. Okay, so now I'll be talking about atopic dermatitis. So, next slide. So, Okay, so how we define atopic dermatitis is a chronic inflammatory skin disorder with a complex pathogenesis involving genetic susceptibility, immunologic and epidermal barriers dysfunction, and environmental factors. So as you okay, so atopic dermatitis is classified under endogenous. Next slide. Okay, next slide. So atopic dermatitis is usually start to develop in early childhood and may persist into adulthood. So the prevalence is around 20%, 20% in some countries, and usually more prevalent in developed countries and urban areas. Okay, so usually there's the reason why it's more high incidence in developed countries is because of this they have this unproven hygiene hypothesis where a decreased early childhood exposure to infectious agent may increase the development of atopic disorder and autoimmunity to self-protein. Okay, so next slide. So atopic dermatitis there's a different factors that plays a role in the pathogenesis. The pathogenesis, simply as Amira has mentioned earlier. So there are 4 factors that play an important role. The first is genetic factors, which is usually the filaggrin, the mutation in the gene encoding for filaggrin protein. Second is the epidermal barrier dysfunction. And third is immunologic mechanism. And lastly, environmental triggers like food, inhalant allergens, irritants, changes in physical environment like the pollution, humidity, microbial infection, and stress. So next slide. So this is the main factors that I've explained earlier. So for this filaggrin gene impairment, so what is filaggrin gene is that it is a component of the conified cell envelope produced by differentiating keratinocytes. And if there's a deficiency of filaggrin, this is the major determinant of defective barrier function. Okay, so then so some of the known filaggrin deficiency is a major determinant of defective barrier function, and other known epidermal barrier defects include decreased ceramides, antimicrobial peptides. There's also increased transepidermal water loss. Then that will allow the increased penetration of environmental irritants, allergens, microbes, and this will then trigger inflammation and sensitization. For immunologic abnormalities, the innate immune system will play a role where the innate immune system is the first line rapid response mechanism to prevent this microbial invasion. So the exposure to the microorganism, usually because of an injured physical barrier, will initiate this immune response that prevent the further microbial invasion and replication. So a defect in this innate immune-mediated epidermal barrier repair process will then lead to the alteration in the skin microbiome and lead to severe inflammation. And also the other factors is the aggravating factors like the dry skin, harsh soap, heat, sweating, infection, stress, and food allergy as mentioned just now. Okay, next slide. Okay, so the clinical features. So the cardinal symptom of atopic dermatitis are intense pruritus and also dry skin. However, this clinical presentation is highly variable depending on the patient's age and disease severity. Next slide. So the clinically, atopic dermatitis has both acute and chronic presentation. So it's like typically like an episodic disease of flare and remission. However, it can be continuous in some patients. So in acute eczema is characterized by red, edematous, scaly patches, or plaques that may be weepy. Occasionally, vesicles are also present. Whereas in chronic eczema, because of due to intense rubbing and scratching over a period of time, the lesions can become dry or called xerosis. There will be also increased scaling and also lichenification. So, okay, next slide. Okay, so during the clinical course of the atopic dermatitis, as I mentioned, there's flares and remissions. So in acute, as you can see in the acute the picture, there's a vesicular weeping and crusting eruption, as mentioned earlier. In the subatopic, there's a present with a dry, scaly, and erythematous papule and plaque. And then there's chronic. It's in the lichen and you can see there's also hyperpigmentation. Next picture. Okay, this one. There's also might present with also this is a lichenific plaque and also a depigmentation resulting from repeated scratching. Okay, next slide. So what are the common distribution of lesion? So this distribution is age specific. So in infants, we usually find the lesion at the face, at the scalp, neck, and unlike in the older one, in older children or adults, in infants can also present in extensive surface of extremities. In older children and adult, the lesion will occur on flexural surface like the neck, antecubital, and popliteal fossa. Okay, next slide. So for diagnosis, I got this one from the CPG, where they use the United Kingdom Working Group on Atopic Dermatitis. So to diagnose atopic dermatitis on a patient, the patient requires an itchy skin condition, an intense pruritus, and also the three of the following. The following are the history of flexural involvement, a history of asthma or hay fever, or can also be in a relative, first degree relative with asthma or any atopic dermatitis. Third, history of generalized dry skin. Fourth is onset of rash under the age of 2 years. And lastly, also visible flexural dermatitis. Okay, so next slide is another criteria of for diagnosing atopic dermatitis called the Hanifin and Rajka. This was also mentioned in the CPG. So according to Hanifin and Rajka criteria, they must have 3 or more basic features of pruritus, a typical morphology and distribution, which is the flexural lichenification or linearity in adults, facial and extensor involvement in the infants and children. Third is the chronic or chronically relapsing dermatitis, and lastly, the personal or family history of atopy. And they must also have 3 or more minor features which you can read in your own time. Okay, next slide. So usually atopic dermatitis can be confused with other skin disorder. So I pick up the 4 most common differential diagnosis. Firstly is the allergic or irritant contact dermatitis. So how do we differentiate is that the dermatitis is localized to a specific skin area, and there's a history of exposure to the irritant or potential sensitizer. And in irritant contact dermatitis, they can use relevant patch test, which Hassan will present later. Second is seborrheic dermatitis, where in seborrheic, there's a salmon red erythematous skin patch with greasy scale, and involves a scalp and little or no pruritus. Next slide. So the left is the allergic contact, and this on the right is the seborrheic. Next slide. The third differential diagnosis is psoriasis. And in infant and young children, psoriasis often involve the diaper area, whereas in atopic, we don't usually find any rash over the diaper area. And lastly, scabies. Scabies involve the skin fold, and also in infants, we're involved in the diaper area. So scabies, they present with vascular pustules on the palm and sole. And we can diagnose scabies with the demonstration of mites or eggs by skin scraping or adhesive tape test. The next slide. So this is on the left is the psoriasis, the right is the scabies. Next slide. So this is the overall picture of the pathogenesis and clinical finding. And I put this for your later reference, so you can read later on. And that's all. Any question?
Okay, well presented, short and sweet. Any questions for the presenter? Any doubts that the group may have? Can we go back to the beginning of his slides? Anybody want to ask a question? He started by just an introduction again, endogenous and exogenous, then atopic and non-atopic, yeah. Then he moved on to the definition. Sorry, go back one. Okay, so he went to the definition and he highlighted complex pathogenesis, isn't it? Because as you can see, it's both genetic susceptibility and other patient factors, along with environmental factors also. There's a bit of overlap, isn't it? Okay, move on. Next slide. Yeah. So he talked about the epidemiology. Yeah, I don't think there are any questions about the epidemiology. Then he talked about risk factors, isn't it? And this is not so much risk factors as triggering factors. I think we could label this as triggering factors. Okay. Which triggering factors would you like to highlight, Brother Ali?
I would like to highlight the genetic factors, as usually we would.
Sorry, in your diagram, you know, you've got the figure 4.6, isn't it? I'm not sure where you took that from. But there are quite a lot of triggering factors there. There are 8 of them over there. So can you tell us 3 or 4 that you think are more important, which you'd like to highlight?
I would like to highlight the food, skin irritation.
Food. Sorry? Irritation.
Skin irritation.
Okay. Food, skin irritation. Any more?
Stress.
Stress. That's all?
That's all.
Okay. Well, I agree with you about skin irritation. Yeah, that's definitely one of the main triggering factors. So let's say, you know, excessive use of soaps and detergents or anything that dries out the skin. right? If the patient is coming in contact with any irritant substances, chemicals, other than soaps and detergents, like for example, in adults with atopic dermatitis, they may be coming in contact with certain chemicals in their job, isn't it? Well, you can think of a mechanic, for example, coming in contact with oils and greases. Yeah, and that's obviously going to aggravate his atopic eczema. Yeah? Or you can also think of hairdresser, right, coming in contact with all sorts of bleaches and coloring agents and all. Yeah, so that would worsen the eczema. Those sort of occupations are not suitable really for atopic individuals. Those who have atopic eczema, which is still active when they're an adult. Okay, because of the skin irritation. Then I think infection. Okay, I would choose infection as another major triggering factor, because they found that infection of the eczematous skin, infection of the damaged skin, especially with Staphylococcus aureus, right, is often responsible for a flare of eczema. Okay? Staph aureus tends to act as a super antigen, right, which means that it non-specifically activates many clones of T lymphocytes. Okay? Even those which are not specific for the staphylococcal antigens, but they can get activated non-specifically. Okay, that's why it's called a super antigen. Yeah? So skin irritation, infection, right? And then I think the next one probably we'd have to go for things like sweating and climate. Okay, because we know that in a hot climate, when the patient is sweating a lot, right, the eczema does tend to worsen. Conversely, in a cold and dry climate also, the eczema worsens. Okay, so these children don't tolerate extremes of weather very well. Okay, neither very hot and humid nor very cold and dry. Okay, and another thing you have to watch out for when you're talking about the environment is air conditioning. Okay, because air conditioning tends to make the air in the room very dry, right? And that can be bad for children with eczema. It can make their skin even more dry than it normally is. Okay, so that's another thing that we have to look out for. Yeah, and then maybe stress. Probably after that we'll think about stress. Foods, interestingly, is not really a major trigger factor. Okay, food allergy in children probably less than 10%. Okay, so it's not really a common trigger factor for atopic eczema. What we need to do is ask the parent, do you think there's any food to which he may be sensitive? Yeah, that he tends to sort of get more itchy after eating that particular food. Have you noticed anything like that? Right? The problem is that a lot of the time, because there's a general belief in the community, right, that children with eczema must be sensitive to food. Okay, there's a tendency to sort of put a lot of the blame on food. Yeah, so they may even be over-reporting. Like some parents are quite convinced that their children are sensitive to seafood and chicken and egg and many things. Okay, but if the history is suggestive, right, you should follow it up by doing allergy testing. And when we do allergy testing, we find that only few of those children are really allergic to those foods. Okay, as I said, definitely less than 10%. Okay, so first screen by history and then follow up with allergy testing, right? And only those who are, proved to be allergic, right, should then be given advice about food avoidance. Otherwise, there's this tendency to sort of blindly restrict a lot of food items, without going through the process of screening and allergy testing, right? Sometimes the child will not be given dairy products, no eggs, no seafood, right? So a lot of the protein in the diet is unnecessarily being removed. Okay, we shouldn't do that, right? We need to go into proper screening and allergy testing before we stop any foodstuffs. Okay, so foods, I think, yeah, it's a trigger factor for a certain number of children, but the number is quite small. Okay, not what you would expect, because the common perception, the general perception in the community is that eczema is due to food. No, it's not. Okay, but food can be a triggering factor in some of the children. Okay, what about house dust mites? House dust mites also not a significant factor. Okay, many of the children are actually positive. If you do allergy testing, you'll find many of them are positive to house dust mites, but it's not believed to be a significant factor in the pathogenesis, for the simple reason that most of the studies have shown when you follow all the house dust mite avoidance measures, right, the eczema does not improve in most of the cases. Right? That's quite different from asthma. In bronchial asthma in children, right, those who are positive to house dust mite on testing, right, they usually improve. Their asthma control improves significantly with avoidance of the house dust mite in asthma, okay, but not in eczema. Right? That's why we don't consider it so significant. Okay, so just things to sort of keep in mind. Okay, moving on. Okay, then he talked about pathogenesis, then he talked about the clinical features. Isn't it? This is all quite clear. I think dry skin is very, very typical. Okay, most of the patients have got obvious dry skin on clinical examination. Yeah, so here again you can see there's an acute phase, there's a chronic phase. Okay, so the lesions usually start acutely, but then later transitions into chronic eczema. Okay, good. Next one. Okay, so he showed some more pictures, examples. Next. Yeah, and the distribution, right, I think he's explained it quite well over there. It's only after the age of 2 years that we see the typical flexural distribution. Okay, so it's only in older children. In infants, the pattern of the lesions is quite different. It's mostly on the extensor. But in older children, we see it settling into the typical flexural pattern. Okay, face is very common site of involvement, starting from infancy itself. Okay, moving on. Okay, and this is the diagnostic criteria, right? We usually use this one because it's much, much simpler compared to the other one which he showed. Okay, the Hanifin criteria is a bit too detailed for practical use in the clinic. Yeah, but this one is very simple, the UK working group criteria. Okay, easy to apply in the clinic. Yes? Okay, moving on. Okay, this is very detailed, very good, but not very practical for use in the clinic. Yeah, Hanifin criteria. Okay, moving on. Then he talked about the differential diagnosis. Okay, continue. Yes, continue. I think that was the last one, was it? Yeah, this was the last one. Okay. Okay, so any questions from the group? No? So that must be a good sign, right? That means everybody understood everything. Inshallah.
Assalamualaikum. I would like to ask a question.
Yes, sister. Al-Islam.
What about the severity of the disease itself? Do we need to classify it? As in CBG, there are many severity tools that we need can be used, right? So, do we do this in clinical?
Yes, That's actually a very good question, sister. I was wondering why Brother Ali didn't include the grading of the severity. Okay, usually when we deal with diagnosis and management of any disease, right? We would like to assess the severity also so that we can choose the appropriate treatment. Yeah. So as you say in the CPG, there are several tools. Okay, for example, SCORAD, isn't it? Which is a scoring system for atopic dermatitis. Yeah. Having said that, one would also have to accept that many of those scoring systems are quite surprisingly subjective. Okay, if you look at them, there's a lot of words like mild, moderate, that sort of thing. Right? It's a semi-objective scoring system, which is open to interpretation, isn't it? Right? It's not really by body surface area or something which we can quantify objectively. Yeah, but still, those are the standard sort of tools for scoring the disease severity. So we should at least know something about it. Yeah. I'm sure Brother Ali has read about it from the CPG. Do you want to tell us briefly something about the scoring?
Sorry, I haven't gone through the score yet.
Oh, you didn't reach that part. Okay, that's okay. That's okay. Not to worry. Yeah, maybe you'll want to have a look at it later. It's just a scale. It's something like a Likert scale. In community medicine, I suppose they would have told you about that. Like a grading from 1 to 5. Yeah, so you sort of subjectively grade it depending on the amount of inflammation, right? Like no erythema, minimal erythema, mild erythema, few vesicles, that sort of thing, right? So there's a scoring system from 1 to 5, okay, which is commonly used. Okay, you could also assess the body surface area involvement to see how extensive it is. Yeah, but these scoring systems tend to be given more emphasis in case of psoriasis, yeah, which we'll discuss next week, inshallah. Yeah, but still, it's good to be aware of it. Yeah? Does that answer your question, sister?
Yes, thank you, Doctor.
Okay, thank you. Okay, so if there are no further questions, maybe we'll move to our next presenter, Brother Hassan, right?
Can you hear me? Okay. Assalamualaikum warahmatullahi wabarakatuh. Yunus Hassan. And next, we'll be presenting about exogenous eczema, which comprises of two types, which is primary irritant contact dermatitis and allergic contact dermatitis. Okay, next slide. Okay. Irritant contact dermatitis is it's a condition which is caused by chemical or metal ions that exert irritant toxic effect on the skin, which basically means anything that damages the keratin, the skin layer of the skin can produce irritation. Okay, within contact dermatitis, which is exogenous, this irritant cause more than 80% of the contact dermatitis, and the effect, the irritant is dose dependent, which means the higher the more exposure the patient have for the dose for the irritants, the more severe the condition will be. For example, if you are hit by an acid, a small amount and a large amount creates a big difference between the severity. And it also non-immunogenic, which means it does not have any sensitizations. Basically means any of us can have the same symptoms when we first encounter the toxins. Also, for the and the effects are cumulative, which means even the irritant is mild. For example, hand soap, which is mild alkali, and can if we wash regularly, frequently, for example, 10 times per day, it will cause to irritation to the skin. And for example of the irritants are chemicals, which is acid and alkalis, organic solvents, which is, for example, paint thinner and soap. And an example is also physical radiation, which, for example, UV or X-ray, and also extremes in temperature in dry climate can cause the skin to become irritated. And also plants can become irritation. For example, in plant sap, if we touch it for example, rengas type of plant in Malaysia, common causes irritation in the lumberjacks workers. Okay, the irritant contact dermatitis can present with chronic or acute symptoms. Acute, mainly presented because the irritant is severe enough to produce the symptoms, while chronic is mild symptoms which progresses for the long period of time. For example, the doctor have said before, hairdresser, which uses hands to long period of time, which soap and hair dye can cause irritation to the hands. Okay, this next slide. Okay, this causes symptoms which mainly are at the hands and the forearms. It is mainly in the back of the hands because the palmar has higher resistance to the irritation, and the hands are the main presentation because it is the most likely part of our body that can become in contact with any irritants, where any surface of the body which comes in contact with irritants can have irritant dermatitis. The symptoms are well defined to the site of exposure. If in acute symptoms, it can cause erythema, blisters, pustules, which if more severe becomes hemorrhage, crust, scales, and erosion. But the main symptoms which differentiates irritant and allergic dermatitis is pain. It is more painful than allergic dermatitis, more painful than itchiness. And if the situation progresses to chronic and he has poorly defined erythematous, scaly patches, plaques, dryness of skin, and lichenification and discoloration. In the picture, on the top picture shows a contact dermatitis on the back of the hands with imposed impetigo, and which causes the skin to become red. And the ones below are the chronic ones, which for the left is for the woodworkers, and for the right is for washing hands frequently. And okay, next slide. Next slide. Okay, that's all for primary irritant. Previous. Okay, next I will explain about the allergic contact dermatitis. Allergic contact dermatitis is inflammation caused by a delayed hypersensitivity reaction, which means it is have prior sensitization to some substance, which is allergens mediated by T cells. It can occur slower than it can trigger with lower concentrations. It's not dose related, which means even a small amount of allergens can precipitate symptoms. and it has a more less poorly defined lesion spreading in the periphery and can become generalized. However, it is still to concise, localized in the area which the it is in contact with the allergen. In the upper picture is we can see there is erythema and the inflammation and uh, raised swelling of the dorsal of the hands. And the ones below, you can see there is straight lines in the skin, which may indicate where the person have brushed against the allergen. For example, when going through bushes. And for the left one is a ring. This is an example of metal allergen, which drink may contain the metal which can cause allergic reaction. Okay, next is next slide. Okay, this is some examples of allergens. For metals, is nickels. Nickel is some metals, for example, in belts, have some amount of nickels where it becomes in contact with the skin, can cause inflammation. You can see in the picture above. And for the top right picture is an chronic allergic dermatitis caused by chromium, which are present in the cement in construction cement. Okay, which is this mostly occurs in the with construction workers. And for allergens can become cosmetics, in fragrances, preservatives, and biocides and pesticides, and also any topical medications, which is, for example, neomycin, benzocaine, and budesonide, as explained this morning. Okay, and patient may also have any sensitive to rubber, which he in contact with rubber gloves have redness of the arms and itchiness, and also rubber boots. And for plants allergens, I have listed a table below. You can read on your own. And some type of resins, which some types of resins can also cause the allergic reactions. Okay, next. Okay, how do we, the main difference between allergic contact dermatitis and irritant contact dermatitis are the allergic is more itchy, while irritant is more painful or burning sensation. Okay, we diagnose both of allergic contact dermatitis and irritant mainly by clinical examination and also history of contact with allergens or irritants. Okay, in allergic contact dermatitis, we can also perform some tests, which is, for example, patch testing, where we apply allergens under the skin to become in contact with the skin. In the top right picture, there are about 50, almost 50 to 8 types of allergens, which placed on the back of the patients, and we can observe the reactions after 48 hours, which it was when the dermatitis will develop. Okay. We can score the reactions based on the how much it becomes inflamed. If there is no mildly inflamed, he have doubtful reaction, weak reaction, strong reaction, and extreme reaction. In extreme reaction can be have coalescing vesicles and also bullae. However, we must also differentiate between irritant and allergic contact dermatitis, where irritant have variable conditions, but it is well circumscribed and has glazed appearance and increased skin markings, which means it is more more clear, has well circumscribed edges. Okay, that's all for me. Any questions? This is my references. Okay. How can we differentiate allergic contact dermatitis and irritant contact dermatitis? Mostly we differentiate by history, whether the patient have come in contact and also the pain. However, we can also differentiate between the how far it spreads from the site of contact, and also we can also differentiate by how fast the inflammation occurs, where the irritant occurs very fast, and it means within minutes, hours, and while allergic can after hours to days. Okay. Any questions? That's all for me. Thank you.
Does that answer your question, brother? I think Sister Africa also had asked, Sister Africa asked the same question in the group, in the chat, right?
Yeah.
Okay. Anyone else? Any question for the presenter?
Assalamualaikum. I have a question. I still don't get it. Why? What is the significance of differentiate between irritant and also allergic contact dermatitis? And in the irritant contact dermatitis, from what I understand, it occurs acutely. But in the slide, it says chronic working in the wartime. Sorry, can you explain once again about that?
Okay. It becomes chronic because irritant dermatitis occurs acutely. However, in chronic condition, the patient repeatedly have become exposed to the irritants daily and daily. For example, in occupational dermatitis, where the patient have come to work and come in contact with allergens, come in contact with the irritants. For example, in construction workers have contact with cement every day, may if the patient have contact irritant dermatitis, it becomes chronic. However, the treatment is simple. Both of these, if we stop exposing the patient with the allergens or irritants, it will resolve resolve.
Yes, basically, what we're saying is that contact dermatitis, dermatitis due to substances that your skin comes in contact with, it can be either irritant or allergic in the mechanism. Okay, so as he mentioned already, irritant tends to be dose dependent. In other words, everybody who is exposed to a high enough concentration of that substance, right, will tend to develop inflammation of the skin. It's a dose-dependent reaction. Whereas allergic dermatitis tends to be more specific to certain individuals only. Okay, like he gave the example of nickel, isn't it? Right now,
Yes.
all of us come in contact with nickel every day. Right, nickel is very difficult to avoid because it's everywhere. right? Your watch and your belt buckle and fasteners and zips and coins and keys. Okay, nickel is basically everywhere around, isn't it? But only about 5% of the population, perhaps, actually develop nickel allergy. Okay, so although we're all exposed to it, it's only some people who develop the allergy, and those are the ones who are genetically predisposed. In other words, it's not a dose-dependent reaction, it's an idiosyncratic reaction. Okay, so that's the fundamental difference between allergy and skin irritation. Yeah? Now, under irritant contact dermatitis, we've got two types. Right? It could be acute irritant contact dermatitis or chronic cumulative irritant contact dermatitis. Take an example. Acute irritant contact dermatitis, there are certain plants, if you come in contact with them, if you touch them, right, you immediately get an irritant reaction, inflammation of your skin at the site of the contact, okay? There will be redness, there will be swelling, there may be blisters, okay? And there may be pain, okay? So that's acute irritant contact dermatitis, yeah? Chronic or cumulative irritant contact dermatitis is substances that are less obviously irritant, okay? For example, soaps and detergents, okay? When you come in contact with it, it doesn't cause inflammation, isn't it? But if you come in contact with it excessively over a long period of time, gradually your skin defenses are impaired and you get low-grade inflammation, okay? But it takes longer to develop, okay? Because these are not severely irritant substances. They're mildly irritant, isn't it? Compared to the other example we gave just now of the plants. Certain plants which are irritant, poison ivy and things like that, right? Or formaldehyde. Formaldehyde is irritant, isn't it? Right? So that's why, a lot of the irritant contact dermatitis that we see in the clinic is actually cumulative. It's chronic irritant contact dermatitis due to milder irritants over a long period of time, right? I think that's what you were asking about, right, sister?
Yes.
Okay. Any other question? Okay. Thank you, Brother Hassan. That was a difficult topic, but you handled it very well. Good job. Thank you.
Welcome.
Shall we move on to the management? Yes. Salam. Sister, are you all right? Okay. Could you just go back one slide? Yeah, okay. Carry on. Okay, thank you, sister. That was well done. Where did you get Dr. Raj's notes from? Where did you get Dr. Raj's notes from? From the seniors. Okay, okay, that's fine. Right. So, would you say that we could summarize the management as confirmation of diagnosis, right? Then assessment of severity, then elimination of triggering factors, and then specific therapy. Yeah? So something like a 4-step process. Management includes diagnosis as well as treatment, isn't it? So first we want to confirm the diagnosis, right? Then we want to identify any triggering factors that may be present and deal with those. Right? Of course, we want to assess the severity so that we can choose the suitable treatment. Right? And then finally comes the actual treatment that's given. Yeah? Okay, so would you say that atopic dermatitis is a clinical diagnosis, or does it need to be confirmed by some test? Are you still there, sister? Yeah. So the first step in the management process would be making sure we have the right diagnosis, isn't it? So how do you make a diagnosis of atopic dermatitis? What did you understand from Brother Ali's presentation? So shall we open the question to the group? Anybody want to answer? How do you confirm the diagnosis of atopic dermatitis? How do you make the diagnosis?
If I'm not mistaken, we use the working group, the criteria, because
Yes, in other words, it's a clinical diagnosis.
clinical diagnosis.
Yes, atopic dermatitis is a clinical diagnosis. Right? There's no single laboratory test which is reliable in making the diagnosis of atopic eczema, so we still rely on the clinical diagnosis, but clinical diagnosis is based on the criteria which you had shown. Okay? Similarly, contact dermatitis, both irritant and allergic, that's also a clinical diagnosis. Okay? When we do patch testing, right, that's basically to confirm the diagnosis, isn't it? To find the responsible agent. Okay, so usually we will be suspecting allergic contact dermatitis clinically and then try to confirm and identify the agent by doing patch testing. Okay, so in case of allergic contact dermatitis, patch testing is indicated for effective management. Otherwise, we don't know how to advise the patient about allergen avoidance when we're not sure what the allergen is. Yeah. But otherwise, the diagnosis of irritant contact dermatitis is usually clinical. It's not based on testing. Okay, and then assessment of severity. For atopic dermatitis, there are well-defined systems, isn't it? Like the SCORAD system, okay, which basically looks at the body surface area involvement, and then also looks at the degree of the inflammatory changes. Okay, looks at the amount of erythema, the amount of dryness of skin, etc. Right, and it's a scoring system. You give a score to each criteria on that list, and then you end up with a final score, that score, and you can use that to determine whether the eczema is mild, moderate, severe, and choose the treatment accordingly. Just following the algorithm which the sister showed just now. So that would be for assessment of severity. Then removing the triggering factors, I think she focused on that one just now. She focused on avoidance, both for atopic dermatitis as well as for allergic and irritating contact dermatitis. Once again, patch testing is quite important for proper management of allergic contact dermatitis. Okay, so that we can identify the correct antigen, isn't it? The one which has to be avoided. Otherwise, it will become a bit of guesswork. Yeah, we can't rely only on the clinical diagnosis. Yeah? And then finally, the specific agents. Yeah? Some of the topical agents which we discussed this morning, and then in more severe cases, other options such as phototherapy and immunosuppressive drugs, yes, which she also covered in detail. Okay, so any questions on the last presentation? Is there a case where patient develops contact dermatitis or eczema complicated with fungal infection? Yes, sister, I think you had asked about this morning as well. It is possible for a patient who has got any type of eczema to have superimposed bacterial or fungal infection. It's possible. How common it is, of course, is a different question, right? If yes, do patients need to use moisturizer? Well, first of all, we need to be quite sure that we are dealing with fungal infection. So as I mentioned in the morning, the simplest way would be to confirm by doing a KOH preparation, potassium hydroxide slide, from the scraping from the skin lesion. Yes, and then if the patient does have fungal infection in one area, right, then you treat that with antifungal, but the other areas can be managed as for, you know, uncomplicated eczema. Okay, so moisturizer on other areas where the eczema is present, not necessarily at the site of the fungally infected lesion. Okay, does that answer your question, sister? Okay, any question for the presenter?
This is not a question, but the explanation. Patch testing, we test for the allergens, which patients are sensitive to. However, this cannot be done when the patient is already have acute allergic dermatitis. We need to treat that with emollients and also avoidance first. After it resolves, about 1 week later, then we can start the patch testing. Otherwise, it can worsen the allergy reaction.
Yes, that's a good point. That's a good point. So basically, you know, when the patient has got extensive eczema, right, patch testing needs to be delayed. Okay, so basically, you have to treat the patient with topical steroids, emollients, you know, anti-inflammatory treatment. When the eczema subsides, then you proceed with the patch testing. But the patch testing is still important. It shouldn't be omitted, right? Because for the long-term management, unless you can identify the allergen, it becomes difficult to advise the patient on avoidance. Okay. Some cases of allergic contact dermatitis, it's quite easy to identify the allergen clinically. For example, nickel allergy. Okay, because quite often the site will be very suggestive, isn't it? Like dermatitis on the wrist because of the wristwatch. Yeah? Dermatitis on the neck because of the brooch. Yeah? Dermatitis on the lower abdomen because of contact with the belt buckle. Okay, so nickel allergy is relatively easier to identify clinically, right? But many of the other allergies, it's difficult to identify clinically. It's difficult to advise, okay, unless proper patch testing is done. So ideally, patch testing should be done, but it may need to be delayed until the acute flare of eczema has been controlled. You're right. Any other question? Okay. Thank you, sister. That was well done. Yeah, I hope your cough gets better soon, inshallah. But thank you for covering the management very well today. Yeah. So if there are no questions, I think perhaps we should end our session here. It's gone on for more than 2 hours, isn't it? Yeah. Ideally, it should be less than 90 minutes, is it, or less than 60 minutes? Anyway, I think everybody's done a very good job of concentrating and focusing, yeah, although it's a long session and a long topic. But thank you to all the presenters for doing an excellent job in simplifying and presenting the important details. And perhaps we should have a quiz next week. That might be an interesting way to see whether everybody remembers. Okay, so maybe we need to encourage everybody to remember what the presenters have talked about today. Yeah, so shall we do that? Maybe we'll have a short quiz next week in the morning session, yeah, before we start a new topic. Okay, so I think we'll stop here. Yeah, next week, inshallah, we'll be discussing I think we should discuss infections and psoriasis as our next topics. Okay, so I'll post the details in the group as usual, inshallah. And so we will meet again next Wednesday morning. Yeah, and we continue our session at that time. Thanks again to all the presenters, and of course, thank you to all the students, yeah, for being present for this session. See you next week, inshallah. Assalamu alaikum.
Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.
Yeah.